Today's topic is gangrene, macroscopic death of tissue with superadded putrefaction is the definition. It affects the limbs, intestines, appendix, etc. In this webinar, I will discuss basically diabetic gangrene. There can be many causes of gangrene, namely arterial occlusion like atherosclerosis, embolism, thromboangiitis obliterans, also called as Burgess disease, endarteritis obliterans, cervical rib, etc. Venous obstruction like deep venous thrombosis can cause gangrene. Neurological diseases like hemiplegia, paraplegia, pressure ulcers can cause gangrene. Traumatic gangrene due to direct trauma like thrombosis or indirect due to crush injuries. Infection, boil, carbuncle, gas gangrene due to Clostridium. Diabetes itself can cause gangrene, and physical causes like radiation, corrosives, medications. So let's talk about briefly on diabetic gangrene. Diabetics possess distinct problems which make their limbs more liable to gangrene formation. Mainly three factors play major roles. One, sugar-laden tissues of the diabetics lower their resistance to infection. After trivial injury to the toe or sole of the foot or the heel, within hours or days, a virulent necrotizing infection may appear which spreads along the muscular fascial plane. The infecting organism may often be gas-producing of the Clostridial group, although any type of infection may occur, including fungal infections. Second, in the lower limb, however, the arterial occlusive disease mainly involves the popliteal artery and its branches down to the pedal arches. It is important to note that in patients who are on dialysis, it is the peroneal artery that is most commonly affected. Arteries proximal to the popliteal arteries are usually not affected, and if affected, show non-diabetic type atherosclerosis. The third peculiarity of the diabetics is diabetic neuropathy. This impaired sensation involves lower limbs, causing injuries and infections on the plantar foot. As a result of this, the pressure areas of the foot, the heel, the ball of the foot develop a neuropathic diabetic ulcer, and due to neuropathy, the muscular involvement may also be seen in the form of loss of reflexes and deformities like Charcot's foot. The feet may be splayed and deformed, calluses may develop in the plantar foot, and if not taken care of, it favors entry of infection. The clinical features of diabetic gangrene are pain and ulceration. There may be loss of sensation. Doppler signal for pulse may be absent. Change of color of skin and temperature when gangrene is impending, and there may be abscess formation. Both dry and wet type gangrene are seen in diabetics. Dry gangrene occurs more frequently in old diabetic patients. Dry gangrene is only possible when the infection factor is minimum and the occlusive factor of the artery is maximum. The gangrene slowly progresses with a line of demarcation. Wet gangrene is more often seen in younger diabetics. Infection plays a major role in forming this type of gangrene, which is very much spreading and can often be lethal. The workup that we'd like to get in these patients are, we'd like to see the blood sugar log at the bedside. We would like to get hemoglobin A1C levels, serum creatinine levels if diabetic nephropathy is a comorbidity, wound culture and sensitivity, ankle brachial index, Doppler study, and arterial duplex studies, and X-ray or MRI if osteomyelitis is suspected. Overall, diabetes should be controlled by medications or insulin or diet control, but vasodilators like cilastazole and pentoxifylline or low-dose aspirin often play a major role. Care of the foot by avoiding injury, keeping it clean and dry, particularly attention to orthotic footwear, is very important. And when there is infection, antibiotics should be prescribed. In early cases, of course, widespread incision and drainage, debridement of the wound should be performed. Careful localized debridement combined with intensive antibiotic therapy has often been successful in saving the limb. The most important aspect of such debridement is the removal of all necrotic tissues. Inadequate debridement, leaving deep necrotic tissues, is the main cause of failure of the treatment. Dry gangrene is best treated by postponing any operation, allowing auto-amputation to take place over a period of weeks. Thank you.